Today's lecture will cover a review of EKGs. We'll start out by reviewing the basic principles of EKGs and how they work. We'll then move on to a review of the cardiac pacemaker cells and the concepts of automaticity and kind of how the heart works. We'll review some of the autonomic regulation that's involved with the cardiovascular system. Then we'll talk in further detail about how the EKG is recorded, how we go about reading an EKG. We'll look at some of the basic cardiac rhythms, some of the basic conduction blocks, and then some of the other abnormalities that we can see on EKGs. As far as the recommended reading, Dubins is an author that has published a book. It's called Rapid Interpretation of EKGs. I believe the 6th edition is out. It's actually it's a really good book. It's a quick read. It's very cheap. You can get it on Amazon. And it's really a great basic read in terms of starting to interpret EKGs. So I recommend that if you're at all interested. So let's start by looking at some of the basic principles. So if we look at some of the basic principles of EKGs, an EKG really is a graphic representation or record that shows us the electrical activity associated with the muscular contractions of the heart. That electrical activity we see is both the depolarization and the repolarization of the heart muscle. We look at depolarization, once again, what we're really looking at here is kind of the advancing wave of positive charges as that electrical signal or wave of conduction moves through those myocardial cells. And that's kind of what we see here. You can see that in the upper left corner, the resting myocardial tissue has kind of a negative charge on the inside, just like a neuron does. And then as that wave of depolarization moves through it, we're going to see a wave of positive charges moving from one end to the other. And so based on where that conduction wave starts, we'll actually see a wave of first the depolarization, the electrical part, followed by then the muscular contraction of the heart. And so we can see in the picture that will physically push the blood from one chamber of the heart to the other. Now, as this relates to the EKG, the electrode, the positive electrode, and there's going to be a positive and a negative electrode that will measure the electrical current. As that positive charge moves towards the positive electrode, that will cause an uptick or a vertical rise in the EKG tracing. And if that electrical positive wave were to move away from the positive lead, then we would see a downtick or a drop in the EKG tracing. So we talk about depolarization once again. You're going to start with kind of a resting negative potential on the inside. And then with this, what you can see initially is that wave of depolarization, that positive wave is going to move towards the positive lead, which is the little red box with the plus sign. And because it's moving towards the positive lead, we're going to see, if we were to graph that out, a rise or an uptick in on the EKG tracing. Now, as we continue that forward, we're going to see that now the gradient is kind of reestablished. That wave of depolarization stops moving towards the positive lead, and on our tracing, that rise is then going to go back to baseline. Now let's move on and talk about automaticity and kind of what that concept means. So when we talk about automaticity, what we're talking about here is the ability of a specific part or a focal area of the heart to just automatically depolarize all by itself. And there's several aspects of the heart that can do this. The two that are of most concern, though, are the SA node and the AV node. These are the generating or pacemaking generator spots of the heart, specifically the SA node. And really what this involves, this automaticity, is that these areas really have they have kind of a structure that allows passive ion movement. They're essentially parts of the heart where the membrane is kind of leaky, if you will, and permits or kind of has a naturally leaky sodium ion channels that allows passive movement of the sodium ions back in. So remember, your ATP pumps are gonna pump the sodium out, but these kind of leaky channels allow that sodium to kind of permeate back in. Now, once we hit our certain firing threshold, though, then we're going to see we've met our firing threshold. Then we're going to see a massive wave of depolarization occur. That's going to be triggered by a massive triggering of the sodium ion channels, all of them to open and allow all the sodium to come in very, very quickly. Now let's look at the action potential kind of tracing here. and we'll kind of compare it. If you remember back with what the tracing looks like for a regular nerve, this one's a little bit different. So the pacemaker, this is an example of the SA node. We're going to start with phase 4, and with phase 4 what we see is kind of a slow depolarization where we're moving where the inside of the cell is becoming more positively charged. So you can see that baseline is down at negative 60 millivolts, but it's not a flat negative 60. It actually is sloped upwards, so it never kind of reaches baseline. It's always it gets reestablished at negative 60 and then kind of becomes more positive until it kind of resets. So with phase 4, what we see here is a slow inward leak of sodium that's coming in. And then we also get a little bit of potassium or calcium coming in as well. Once we reach our firing threshold of about negative 40 millivolts, though, that's where we're going to see a massive influx of calcium coming in. These are the long-acting calcium channels. So the calcium channels will open up, the calcium ions will come rushing in. We can see that the internal charge is going to become much more positive. It's going to change from negative 40 millivolts all the way up to positive 10 millivolts. All right, and then additionally, that calcium coming in is also going to trigger muscular contraction, so that the muscles start to squeeze. All right, now phase 3 is the downward slope, the kind of resetting phase, and with that, what we see is kind of the repolarization. So the potassium ions or the ion channels are going to open up. We're going to see potassium moving out of the cell. That allows the internal charge to reset, because we have those positive ions moving outward, so that's going to make the internal aspect of the cell more negatively charged, and ultimately it'll reset all the way back down to negative 60 millivolts, and then this cycle will kind of it'll restart. Now, in terms of the normal impulse conduction, we'll walk through that. So the SA node, or the sinoatrial node, that's the start. Typically that's the start or the first part of the wave of depolarization. That's in the upper right atrium. And so you can see the wave starts there, and then it's going to move through the atrial muscular tissue, cardiac tissue, and then it's going to kind of wrap around and end up at a bottleneck, which is also otherwise known as the AV node. All right, from the AV node, then we're going to move down the bundle of His to the His-Purkinje, the bundle fibers to the Purkinje fibers, and then kind of back up. So initially we go through the AV node down to the apex of the heart and then back up, and what that does is that allows the ventricles to contract upwards and squeeze or eject the blood upward through either the pulmonary veins or the pulmonary arteries or the aorta. Now, if we look at some of the pacemakers of the heart, once again, the SA node, as I mentioned, that's the dominant pacemaker. The intrinsic rate at which it kind of automatically depolarizes is somewhere between 60 to 100 beats per minute. Now, the AV node is the secondary or kind of backup pacemaker, and its intrinsic rate is about 40 to 60 beats per minute. Now, one of the things that's kind of interesting is, as long as the SA node keeps depolarizing within that intrinsic rate, and if that intrinsic rate is faster than what the secondary or backup pacemaker sites would be, then it prevents those secondary pacemaker sites from kind of triggering and firing. All right. And if we look, then there's the backup, the super backup, if you will, pacemaker cells, otherwise known as the ventricular cells, and it can be anywhere in the ventricles. It's not one particular site like we see with the SA or the AV node. But those ventricular cells have a very, very slow intrinsic rate of right around 20 to 40 beats per minute. So let's say if you had a patient whose SA node stopped working, their AV node would kick in, and so their intrinsic heart rate would be somewhere around 40 to 60 beats per minute. And if that failed, the SA and the AV node stopped working, then somewhere in the ventricles, another pacemaker cell would kind of start firing all by itself, and then that would set the pace for the heart. And that intrinsic rate would be very, very slow, right around 20 to 40 beats per minute. Just another slide to kind of summarize. So we have those foci where we have this concept of automaticity, where those sites will just kind of cycle on by their inherent rate. They'll just kind of depolarize all by themselves. So the SA node is first, then the atria. You can see the SA node is the fastest, 60 to 100 beats per minute. Somewhere the atria is a little bit slower, about 60 to 80 beats per minute. Then the AV junction, the AV node, is about 40 to 60. And then the ventricles is 20 to 40 beats per minute. And so as long as we have, whatever's higher, whatever's depolarizing faster inherently is going to suppress everything that would inherently depolarize at a slower rate. So that's why we see the SA node kind of being the main driver here, is because it depolarizes at a faster rate than everything else, and that prevents any of the other foci from depolarizing. Because essentially once the SA node depolarizes, it causes a depolarization of all the other tissues, and then the clock kind of resets. And so every time the clock resets, the next thing to depolarize is the fastest, which would be the SA node. So once again, the SA node is the dominant pacemaker. As you can see, the wave of depolarization, once it's generated, that depolarization wave kind of flows from the SA node in all directions. It's very similar to if you had a still body of water and you threw a rock in the middle of it, right? That wave that you would generate from the rock splashing in the water creates, that as that rock splashes in, it's going to create a wave that will move away from where that rock entered the water at an equidistance. And we see the same thing in the heart tissue. Now, as you can see, the SA node is in the right side of the heart, and that's also going to we'll see that wave of depolarization actually jump over to the left atria as well. So when both atria start to contract, that's going to, and depolarize and contract, we're going to see the movement of blood from the atria into the ventricles. Now, we want to make sure that we give ample time for the blood to actually physically be pumped, and so part of that, we need to give that time. We need to slow that electrical wave of conduction down just a little bit to help isolate the atria from the ventricles, because we want to make sure that the atria contract first and then the ventricles can contract. We need to be able to separate or isolate the atria from the ventricles, electrically speaking. And our AV valves really kind of help do that. They help electrically isolate the ventricles from the atria. Now, the other thing that those AV valves do is they help to prevent the blood from being pushed backwards up into the atria. So they're kind of one-way valves to allow the blood to move from the atria into the ventricles, and then they're going to slam shut and prevent that blood from moving backwards. Next is the AV node. The AV node, in terms of its location, it's located on the right side of the interarterial septum, or atrial septum, near the ostium of the coronary sinus. You can kind of see where it is on the right side there. And really, its main job essentially is to act as kind of like a gatekeeper and to slow the electrical conduction wave down to give a brief second, a split second, to allow the atria to physically pump or move that blood from the atria into the ventricles. So kind of stepping back for a second, when we see the SA node and the atria depolarize, that is the P wave that we see on the EKG. So that little P wave tells us or is responsible or coincides with the depolarization of the atria, both the right and left atria. All right, now we're going to see a brief pause there, and that pause is you can see that pause because the signal, the P wave goes up and down, and then we see it goes back to baseline, and it stays at baseline for just a split second. So while we see that baseline there, that means there's no depolarization moving in any direction. All right, so the AV node is going to slow the depolarization down. Next, you can see the electrical conduction is going to move down the His-Purkinje system. So we have the SA node once again, then the AV node, then the bundle of His. All right, so we see the P wave, which is going to correspond with the SA node, and then we see that brief pause. That's the AV node. Then we're going to see the bundle of His, then the His-Purkinje, the bundle branches and the Purkinje fibers. That is that coincides with the QRS complex, and so the QRS complex illustrates the depolarization through the ventricles. All right. Now, buried in there within that QRS complex is the repolarization of the atria, but we don't see it because it kind of coincides and happens at the same time as the depolarization of the ventricles. And because the ventricular mass is so big, the electrical conductions generated there is sufficiently large that it really masks or covers up the atrial repolarization that we otherwise would see. So here you can see the ventricular contraction. You've got your His-Purkinje, your bundle fibers, your His-Purkinje system. And remember that the goal here is to really go from the AV node. We want to go all the way down and back up so that we can get a nice coordinated ventricular contraction that moves from the apex back up and is going to squeeze blood from the ventricles into either the aorta or the pulmonary artery. And once again, the ventricular contraction is illustrated on the EKG tracing by the QRS complex. So in terms of the ventricular activity on the EKG, once again, the uptick, the QR part is the depolarization. I'm sorry, the QRS is the depolarization. And then we certainly have to repolarize that ventricular tissue. And we see that on our EKG. It's reflected by the T wave. All right. So the P is the atrial depolarization. The QRS is the ventricular depolarization. Buried in that, which we can't see, is the atrial repolarization, and finally the T wave is the ventricular repolarization aspect. Here we can see that defined once again. You can see the repolarization broken down. We've got our ST segments and then our T wave. Now so the PQRS, we can see the different components. Once again, this is kind of a nice summary. So the P wave, atrial depolarization. The QRS complex, you can see it's ventricular depolarization and atrial repolarization, and finally the T wave, which is the ventricular repolarization. Now let's talk about some of the controls for the cardiovascular system, specifically those under autonomic control. All right, so we can see that the heart, just like a lot of the other end organs, receives innervation from both the sympathetic and the parasympathetic nervous system. And we can see that the SA node and AV nodes particularly both receive sympathetic and parasympathetic innervations. So the sympathetic is the excitatory, and in this regard it's going to increase the rate of the automaticity of those cells. It's also going to stimulate or enhance the contractility of the myocardial cells, and it'll make the cells, the electrical conduction cells, actually depolarize faster. All right, so all that summarized together, the sympathetic response that we see, it's going to make the heart rate increase. It's going to make the cardiac output increase, not only because of the increased heart rate, but also because the heart can actually squeeze and pump stronger. All right, now the parasympathetic is going to act as an inhibitory. It's going to slow everything down. It'll slow the depolarization. It'll decrease both the rate of conduction and the contractility. So we have this kind of balance that we see between the parasympathetic and the sympathetic nervous system in regards to its controls, both on the SA and the AV nodes. So as you can see, the sympathetic nervous system actions are mediated by the beta adrenergic receptors, specifically the beta 1 adrenergic receptors, and the effects that we see from that are an increase in the SA node rate of depolarization, an increase in the speed of conduction along the conduction systems. We're going to see an increase in the strength generated by the muscles, and then we'll also see, as a result of that, an increase in the irritability of the other foci along the way. So if you give, let's say, a catecholamine like epinephrine, one of the side effects is that you can see other sites depolarize. We can see that typically in the ventricles, where we may see a premature ventricular contraction, or PVC. The parasympathetic system, though, what we'll see with that is kind of the opposite. Remember that that's mediated by the vagus nerve. So the cardiac effects that we'll see there are kind of slowing things down. So we're going to see a decrease in the rate of depolarization of the SA node, a decreased rate of conduction and contractility, and then a decreased chances of atrial or ventricular irritability of their foci. Now let's talk about the recording of the EKG and kind of look at how that's done. You can see here is an example of the EKG paper, and you can see from the drawing that we've got down below, we've got big pink boxes and little pink boxes. Now if we look at what these mean, each of the big pink boxes, as we can see by the big black box here, is what that means is, in terms of time, is each big black box or pink box is equivalent to 0.2 seconds. Each little box then is 1/5 of that, so it would be 0.04 seconds. And you can see in terms of the voltage, which goes up and down, that 5 millimeters or one pink box again is equivalent to 1/2 of a millivolt. So we've got millivolts going up and down, and then time going horizontally. All right, so this is kind of what we see here. Here you can see the box that we're talking about, the big pink box. All right, so horizontal axis is time. One small box is 0.04 seconds. One large box is 0.2 seconds. And the vertical axis is voltage, with one large box being 0.5 volts. And here we can see that once again. You can see the different tracings. We'll talk about each of these as we kind of move along. So the EKG paper, if we look, it's not only do we have the little boxes, but we also have these vertical tick marks or vertical lines every 15 large boxes or so. So what if we add up the time, though, each of those big black lines, which is what we see here, they're actually red, that is the equivalent or marker for every 3 seconds. And so that helps identify 3 seconds intervals, so it helps us calculate the heart rate. Now we'll talk about the different leads. There's a lot of different EKG leads you can use. There's the limb leads that go Roman numerals 1, 2, and 3. Then there's the AVR, AVL, and AVF. That stands for the right, the left, the augmented right, the augmented left, and the augmented foot. And then we can see the chest or precordial leads, which go V1 through 6. So with the limb leads, once again, that's the Roman numeral 1, 2, and 3, otherwise known as Einthoven's triangle. Those are the bipolar limb leads. So we've got a negative lead and then a positive lead. Okay, so there's 2 leads there. So lead 1 is at the top of the triangle. It's going to go from the right arm, which is the negative lead, to the left arm, which is the positive lead. All right, lead 2 is going from the right arm, which is negative, to the left leg, which is the positive. All right, and then we've got lead 3, which is the left arm being negative to the left leg being negative, and so that completes our triangle. Now, the other thing that this does is, if you imagine, a person standing up and placing these EKG leads on, that gives us information in the frontal plane, kind of the vertical part. All right, so that's 1/2. We need to know in kind of 3 dimensions. So we've got, one part, one plane here. So here's our bipolar leads, and then you can see our augmented leads down below. AVR is a combination of leads 1 and 2. AVF is a combination of leads 2 and 3. And then AVL is a combination of 1 and 3. And so by being able to combine them together, that gives us some additional information. So you can see now we've got a lot of information that we can glean from the leads placed in this frontal plane. Now the precordial leads kind of wrap around the heart horizontally. It measures the electrical activity in the axial plane. So we've got the frontal plane and then the axial plane. Lead V1 and V2 kind of run along the septum. V1 is placed to the right. It's more of the right anterior aspect. V2, 3, and 4 run along the septum, along the front of the heart. V4 is kind of along the left. And then V5 and 6 kind of wrap around the back side, and that gives us information around the left posterior aspect of the heart. Now, in terms of reading the EKG, when we read an EKG, what we want to look for at each time is we want to get a sense for what the rate is, the rhythm is, what axis are we looking at, do we see any signs of hypertrophy or any sort of abnormalities like an infarction, and we'll kind of through each of these. All right, so the first thing we need to look at is the rate. How do we calculate the rate? All right, so this is kind of method number 1. The first thing we're going to do is count the number of R waves in a 6-second strip and then multiply by 10. And if we do that, this answer is always correct. It's a surefire way to get it right. There's some other ways that we'll talk about, but if we ever see anything funky, this is kind of a nice, easy go-to kind of backup method, the non-shortcut method. So once again, we're going to identify on our strip the big vertical markers here. So you can see the vertical markers indicate every 3 seconds. So we've got 2 sections here. All right, so we'll count the R waves. We can see we've got 1, 2, 3, 4, 5, 6, 7, 8, 9. 9 times 10 would be 90. All right, so our number of beats per minute is about 90. Once again, the number of R waves in a 6-second strip and then multiply by 10. Now, the alternative way to do it, the kind of shortcut, is to find an R wave that kind of lands on one of those small bolded lines. Those little black boxes are big. I'm sorry, the big pink box or the the big black box. All right, so here with this, back to our tracing here, you can see that the R wave on this tracing falls on that big black line there, or big box. All right, and so we're going to count over to see where the next one would be. All right, so the first box would be 300, 150, 100. You can see the R wave falls somewhere between 75 and 100, so maybe upwards of 85 or 90, something like that. All right, so we're going to count the rate, memorize the sequence: 300, 150, 100, 75, 60, 50. We know that that is going to fall somewhere a little bit less than 100, so 95, 90, 85, something like that. The next thing that we want to do is take a look at the regularity of the rhythm. Is it regular or is it not? Do we see equal spacing between each of the R waves? If we do, then the rhythm is regular. All right, so we're going to look at or measure, and you can actually do this with calipers or markings, and kind of figure out, is the distance between each of the R waves regularly spaced? All right. Is it regular? Are they equal distance apart? Is it occasionally irregular? Is it regularly irregular? Or is it just completely random, meaning that it's irregularly irregular? And each of these is suggestive of possible arrhythmias. So with this, we can see that the R waves are pretty evenly spaced. So I would say that in terms of the regularity, this is a regularly, it's a regular rate and rhythm. Next thing we want to do is assess for P waves. Are they there? And is there a P wave before each QRS? Are they there, and do they all look alike? All right. Remember that if the waves look alike, then they're all originating from the same spot within the heart. If we see differences or changes from one P wave to the next, or one QRS to the next, then that tells you that that wave of depolarization is coming from a different spot. They're not the same place. All right, so with this, we can see that each QRS is preceded by a P wave. All right, so we can see, yep, each one has one. All right, next we want to look at the PR interval, the spacing between the start of the P wave and the start of the R wave. All right, so normal would be anywhere between 0.12 to 0.2 seconds. So once again, that's somewhere around one of those big boxes. All right. So with this, we could see that that the PR interval looks normal. All right. So it's actually a little bit less. It's 0.12 seconds. So that's normal. That's what we expect. All right. The next thing we want to look at is the duration of the QRS complex. It should be somewhere between 0.04 to 0.12 seconds. All right. So that's going to be anywhere between 1 to 3 little boxes. All right. So with this, is the QRS normal? Yes, it is. It's about 2 boxes, so that's 0.08 seconds. All right. Otherwise, if it was prolonged, we would see prolongation of the QRS complex, and that can be suggestive of some disease states. So the summary here, we can see the rate is somewhere between 90 and 95 beats per minute. We can see the rhythm is regular, the P waves are normal. The PR interval is normal, and the QRS duration is normal as well. So this would be a normal sinus rhythm pattern that we see. Now the cardiac rhythms that we can see, these are some of the ones we'll talk about. This is certainly not an all-inclusive list, but see that these are some of the more common or notable arrhythmias that we can see. We'll talk about sinus rhythm, we'll talk about sinus arrhythmia, sinus bradycardia, sinus tachycardia. We'll look at AFib and aflutter. Then we'll spend a little bit of time on ventricular tachycardia or ventricular fibrillation. All right, so the sinus rhythm, what do we see? We see a P wave, yes. And so because we see a P wave, we know that that's going to originate in the SA node. The PR interval should be normal. It should be less than 0.2 seconds. And we should see a normal QRS complex, a narrow QRS complex. So it should be, anywhere between 0.12 to, it should be less than 0.12 seconds. So, anywhere between 0.04 to 0.12 seconds. For sinus rhythm, the rate should be between 60 to 100 beats per minute. Remember that the SA node, the inherent rate of depolarization is somewhere between 60 to 100 beats per minute. And with sinus rhythm, the R to R interval should be normal, should be equal. Now we can see some differences in an otherwise healthy patient where we see this pattern where the the R to R interval tends to kind of accordion up and then spread out, and then accordion up and then spread out. But we still know that this depolarization is originating from the SA node, because we see the P wave looks normal, we see the normal PR interval, we see the normal QRS, so everything looks good. It's just that the R to R interval is not equal, and it just kind of has this pattern of where it kind of bunches up a little bit and then spreads out. And this is called sinus arrhythmia. And really what that is we see an increase in the rate with inspiration. All right, and so that's a normal variant. When we see it, look for it, you'll see it, and just know that that's a normal finding. Now, what about sinus bradycardia? Sinus bradycardia is just like sinus rhythm, except the rate tends to be less than 60 beats per minute. Once again, the R to R is typically equal. And is this the concern? Well, no, not typically, assuming that they're not symptomatic and their blood pressure is fine. But if it's very, very slow, 40 to 45, 50, and they're symptomatic, they pass out, their vasovagal syncopal reactions, things like that, that can be of concern. All right, so with here, once again, what we can see is that we see the P wave, we've identified that. We've looked at everything else looks normal, except for the rate being inherently slow. It's slower than 60 beats per minute. Now, with sinus tachycardia, the opposite. We see everything, once again, is still normal, except for this, the rate is above 100 beats per minute. Once again, the R to R is typically equal. And the concerns, when am I concerned about sinus tachycardia? Well, once we get an elevated heart rate in a normal, healthy patient, above 140, we start to see a decline in the cardiac output. The heart simply just is beating so quickly it doesn't have time to fill properly. All right, so it gets worse the faster the heart beats, and this really starts right around 140 beats per minute. Now, in select patient populations, patients that have underlying cardiac disease, I'm certainly concerned above 100. That doesn't mean I'm always going to intervene, but depending on the other comorbidities going on, I may intervene at a much lower degree than 140. The other thing is, when your heart's beating so quickly, not only do you have decreased cardiac output, but you also have increased myocardial stress or work on the heart, because the heart is simply moving so quickly. It's really burning through oxygen very, very quickly. Next, let's talk about atrial fibrillation. With atrial fibrillation, you can see here that no longer do we have a P wave. So everything else is there. We have a QRS and a T wave. So we know that we've got ventricular depolarization and then repolarization, but we've lost our P wave. All right. The other thing is, with AFib, essentially, instead of having a nice, organized wave of depolarization moving through the atria, essentially what we have are all these different foci in the atria kind of depolarizing all at once, and so the atria really respond by essentially just sitting there and quivering. They don't actually, the muscle doesn't actually have a nice organized contraction. It just sits there and kind of essentially shakes. And the rate at which it shakes or depolarizes is very, very quick. It can be upwards of 350 plus times a minute. So very, very, very quickly. Now you can see that the AV node is still intact, and the AV node is essentially what is preventing that rapid rate of depolarization from being able to essentially trigger the same rapid response in the ventricles. So with this, you can see either a slow or a fast rate, depending on whether or not the AV node can keep up and act as the gatekeeper. If the rate is slow, depending on how the patient's doing, if they're stable, everything could be fine. But if the AV node can't keep up and act as a gatekeeper, then what we have is kind of a rapid fire, rapid ventricular response, where the ventricles are just consistently being bombarded with depolarization waves that lead to massive uncoordinated filling of the ventricles, and then a rapid decline in ability to lead to decreased cardiac output, and the patient becomes symptomatic. And this can be kind of a very, very bad downward spiral. So some of the concerns we have with atrial fibrillation, because we don't have that coordinated atrial contraction, we lose the fill that we would otherwise get. And that atrial fill and contraction that we get pushes about 30% of the blood. With that being gone, the ventricles lose about 30% of the volume of blood they otherwise normally would have had. So the ventricles aren't filled as much as they used to be. If we run into a scenario where we have rapid ventricular response, the AV node is no longer acting as a very good bottleneck and is not able to continually block the wave of depolarization from reaching the ventricles. The ventricles start to depolarize very, very quickly, and that can lead to very, very quickly lead to massive increases in the workload for the myocardium. Now, if we have a scenario where the patient has never been diagnosed with AFib before, and now it's new onset AFib, and then they're symptomatic and we need to manage it, the way it's managed is typically either through rate or rhythm control, or they can be electrically cardioverted, kind of similar to using the paddles on someone. If it's a chronic AFib, typically what they do is they don't manage the rate too much. They try to control the beta blockade to help the AV node continue to act to prevent the rapid ventricular response. But the other thing they do with that is they put them on blood thinners to really help minimize any sort of thrombus from forming the atria, because that blood can be stagnant in the atria, and then if and when it would contract, you can imagine if the blood's stagnant and we get a clot forming there, that clot is going to be pushed into the ventricles and then it's going to be pushed out to the rest of the body, and that can certainly be problematic in terms of causing a stroke or a heart attack, etc. Next, let's talk about atrial flutter. Atrial flutter is very similar to AFib, but with this, the rate is much slower. You can see the rate of the atrial depolarizations is somewhere around 250 to 350 beats per minute. And really what we have here is an establishment of a reentrant loop in the atria. And so it's kind of this cycle where we have a depolarization wave that just kind of continues to feed back on itself and just kind of continually cause a depolarization of the atria. The QRS can be, once again, it can be fast or slow, but typically it's a very narrow QRS, indicating that the AV node is still functioning. And if it's fast, then we're worried, just like we were with AFib, that we can get into this rapid ventricular response and the patient can become unstable due to the loss of cardiac output and increased myocardial workload. All right, so some of the concerns with atrial flutter, very similar to AFib, we lose that atrial kick, that atrial fill. So we've lost about 30% of our ventricular fill because of the loss of the atrial coordinated contractions. If we have a rapid ventricular response, that's going to lead to a decrease in cardiac output in addition to the increased myocardial workload. Just like with AFib, the same in regards to whether it's new onset or old onset and how it's kind of managed. Next, let's talk about premature ventricular contractions. As I mentioned before, we can have contractions of the ventricles if they're not, or if they've become irritable due to some catecholamines or a lot of other things that can kind of make them hyperirritable. With PVCs, or premature ventricular contractions, we can identify them very easily because of their unique shape. You can see that the QRS complex, instead of being very narrow, is stretched out and it's much, much wider. It's well beyond the normal 0.04 to 0.12 milliseconds. And so what we see is no P wave at all. We see a widened QRS, and the QRS can either be unifocal or multifocal. And we can see in the diagram over on the right-hand side, it's a nice example of a unifocal PVC. You can tell they're unifocal because every time the PVC happens, they look the same. So it's originating from the same spot in the ventricles every time. Now, multifocal PVCs, you can tell they're PVCs once again because of the unique shape, the widened QRS, but you can tell that those come from two different foci in the ventricles, and you know that because they look totally different. They come from two different shapes. All right, so some of the concerns with PVCs, they help illustrate and point out to us that the ventricles are being irritated or hyperirritable. Now, the most common cause of ventricular irritability or increased ventricular irritability is hypoxia. When you start to deprive the myocardial tissue of oxygen, the electrical conduction system becomes very irritable, and we see an increase in the rate of PVCs. We see the same thing if we utilize or stimulate the heart using the sympathetic nervous system with our vasopressors like epinephrine. That's going to predispose patients to having hyperirritable ventricles, and they're going to have an increased incidence of PVCs. We can also see the same thing with increased acidity. If the if we see an increase in the carbon dioxide retention and the blood becomes more acidic, let's say the patient's not breathing adequately and they start to retain carbon dioxide, the increase in hydrogen ions and the resulting decrease in pH of the blood can make the ventricles hyper irritable, and we can see PVCs from that as well. Now, if we see a run of PVCs in a row, if we see 4 or more, that's defined as ventricular tachycardia. And the big deal with ventricular tachycardia is this not only illustrates a loss of cardiac output because we've lost kind of the normal functionality of the heart. We lost that coordinated atrial fill and then giving time for the ventricles to fill. All that is out the window. In addition to that, one of the other big problems with ventricular tachycardia, besides the loss of cardiac output, is that this has the penchant for progressing very easily into ventricular fibrillation. So when we see ventricular tachycardia, it's very important that we identify this right away, and then we need to manage it, and it's usually treated immediately by giving these patients electricity. They need to be defibrillated. Now, with ventricular fibrillation, kind of similar to AFib, what we have here is irregular depolarizations, and instead of having nice coordinated contractions of the ventricles essentially just sit there and they quiver. They just sit there and kind of shake, and because of that, we have a massive loss of cardiac output. There's no coordination whatsoever. We see no blood being moved, essentially. We also see a dramatic increase in the myocardial workload because those muscles are just sitting there twitching, and so ventricular fibrillation, is especially bad for those 2 main reasons. Ventricular fibrillation, because it is coincided with a loss of cardiac output and a loss of perfusion to the body. We need to immediately intervene. We start with CPR to provide support for the perfusion of the body, and then also that we need to be providing these patients with electricity. They need to be defibrillated immediately to try to convert this back into a perfusable rhythm. So next, let's look at some of the basic conduction blocks. So a conduction block essentially acts as a dam within the normal electrical conduction pathways of the heart. And there's a lot of different types of conduction blocks. We'll look at some of these here, some of them in greater detail than others. We've got a sinus block, we've got AV or atrioventricular blocks. That can be subdivided into first degree, second degree type 1, second degree type 2, and then finally third degree heart block. We've got bundle branch blocks and then a hemi block, and we'll look at some of these. With a sinus block, essentially what we have here is an unhealthy SA node that's going to miss 1 or more cycles, and we see this pause. And then afterwards, the SA node kind of picks back up. All right, so we can see several, normal, what look like normal sinus rhythms, one after the other, and then all of a sudden we get this pause, and then things kind of restart. And while we're waiting for the SA node to kind of restart, that pause may give an opportunity because of the lack of automaticity overdrive. It may give an opportunity for an alternative site to kind of kick in. And so if we can see, we may see a PQRS T wave that looks different than the other ones, and that tells us that, well, the SA node stopped and then somewhere else in the atria kind of picked back up. Or we may see a wave that just has a normal QRS but no P wave, which in that case that's originating from the AV node. So the SA node kind of pooped out, the AV node said, oh, it's my turn, and kind of kicked on, right? And then the SA node kind of kicked back up again and then turned the AV node off, right? So we can get that. We can also see the same thing with the ventricle, where we can see, like a PVC in there. And what happened was the SA node kind of pooped out, the AV node didn't kick on, but the ventricle said, hey, wait a second, I haven't been suppressed, I'm going to go ahead and fire. And then in the meantime there, the SA node has time to kind of reboot. Next, we'll talk about first degree AV block, and what we have here is a normal slowing down between the atrial, the SA node depolarizing, or the atria depolarizing, and then the conduction through the AV node to the his Purkinje system. You can see that normal, and so this is reflected by a prolonged interval between the P wave and the R wave. So the PR interval is going to increase. Remember that normally the PR interval should be between 0.12 to 0.2 seconds. And so with this, what do we see? We're going to see an increase in the length beyond 0.2 seconds. All right, so now that PR interval is bigger than one of the large squares. So some of our perioperative concerns regarding AV block first degree, it illustrates that we have some sort of impaired conduction in the AV node, and it can either be transient or permanent. Often that can be due to, especially if we've never seen it before, it can be due to increased vagal tone from increased parasympathetic activity. Certainly a lot of the drugs that we use can have activity on the AV node and kind of slow things down. Or they could be having a myocardial infarction involving the AV node. So these are all options or potential causes as to why the patient is having first degree AV block. Of particular importance, though, is the fact that very rarely does first degree block progress to a complete heart block. Some of the other ones do, and that's why we'll talk about these. But first degree heart block typically isn't that big of a deal. In terms of when to use caution, if the patient's asymptomatic, often we can proceed. One of the things that we can do is consider administering anticholinergic drugs to help compensate or overcome the increase in vagal tone. So we can kind of basically block some of that vagal activity using things like glycopyrrolate or atropine. Now, of particular note would be if the patient becomes symptomatic, or if they're a very low pulse, meaning they're low heart rate, they can have a loss of cardiac output sufficient to where they may become lightheaded or start to have symptoms suggesting that they're not being perfused adequately. Next, let's talk about second degree type 1, otherwise known as Wenckebach. And what we see here is a normal QRS, P wave with QRS, and then occasionally we just see a P wave with no QRS. And so what that tells us is that we have the SA node kind of cranking along, and then every once in a while that depolarization is not transmitted to the ventricles. All right. With this, though, we also see a gradual lengthening of the PR interval. So that PR interval will start out normal, and then it gets a little bit bigger, and then a little bit bigger, and a little bit bigger, until all of a sudden we don't have a QRS that we can see. We see the P wave, but no QRS. And then it kind of resets. It goes back to normal PR, normal PR. It's going to get a little bit bigger, and then all of a sudden, once again, a P wave, but no QRS. So some of our perioperative concerns regarding type 1 Wenckebach block. Once again, this is suggestive of some sort of impaired conduction in the AV node. It can be transient or permanent, just like first degree is. And just like first degree, very rarely does this progress to complete heart block. Often this has more to do with an increase in the vagal tone. And so we do a lot of the same kind of management techniques. Typically, we'll just note this, assuming that especially if the patient's asymptomatic. If it's at all worrisome, then we can consider decreasing the vagal tone by administering things like atropine and glycopyrrolate, a lot of our anticholinergics, to block that vagal tone, and then this should improve. So second degree type 2, otherwise known as Mobitz. This is a little bit different than what we saw before, because with this, we still see the P wave that occasionally is without the QRS, but with second degree type 2, we can see that the PR interval is static. It stays the same. It's fixed. It doesn't gradually increase. All right. And so what we'll see, though, is P wave with a QRS, and we'll see that maybe a couple times, and all of a sudden we see a P wave with no QRS. And so we see this pattern that kind of develops. And then we can look at the ratio between the atrial depolarizations, i.e. the P waves, and then the ventricular response that we see, the number of QRS complexes. And we can kind of look at the different ratios. So up above, we can see that we have a 3-to-2 ratio of atrial to ventricular depolarizations. Down below, you can see it's a 3-to-1 ratio. So in terms of our perioperative concerns with a type 2 Mobitz block, this is pretty indicative of fibrous degeneration of the conduction system. Usually it's indicative of underlying disease that's below the AV node itself. This tends to be permanent, so it's certainly much more problematic. And the big problem here is that frequently Mobitz type 2 progresses to a complete heart block, where you have complete separation between the atrial activity and the ventricular activity. So with this is something that we're going to, if we identify this is one where you stop the procedure and you're immediately going to refer them to the hospital for management and treatment. Oftentimes with Mobitz type 2, patients are symptomatic because they have a decrease in cardiac output, so they complain of lightheadedness. You can see syncope, etc. Those are all especially problematic. Once again, we're going to stop treatment immediately. We're going to consider transcutaneous pacing. That's the way this is managed. And then referral to a cardiologist if they're stable. Now with this, if I had a patient that even was stable and I identified, they were normal on their EKG, and then halfway through the case they developed, Mobitz type 2, and I can easily identify it as Mobitz type 2, I'm probably still going to refer them to the hospital right away, even if they're stable, because of the risk that this can progress into complete heart block. Next, we'll look at third-degree heart block, otherwise known as complete heart block, and here what we see are the P waves, which are completely dissociated from the ventricular response. So we see the atria doing their thing, and then essentially the ventricles are doing their thing, and they're totally not coordinated at all, and that's especially problematic. Now the QRS can be narrow, which suggests that the atria are still kind of tacking away, doing their thing, but the response then for the ventricles is originating in the AV node, or further down in the junctional wiring, if you will. And the rate there tends to be around 40 to 60 beats per minute, or it can be a widened QRS, which suggests that the automaticity foci for that rate and rhythm would be within the ventricles. Now the problem there is that the rate is probably somewhere around 20 to 40 beats per minute, and that's so slow that the ventricles are essentially not capable of keeping up with the cardiac output demands for the body, and so the body begins to be underperfused. So with third-degree heart block, once again, this reflects fibrous degeneration of the conduction system, very similar to second-degree Mobitz type 2. It's typically permanent. They have a severe risk for asystole and sudden cardiac death. Patients are often report symptoms like lightheadedness and syncope, all reflective of the decrease in cardiac output. Once again, this is treated with transcutaneous pacing in the emergent time. And then you're going to refer them to the cardiologist. So this is, once again, a big deal. We see this, we're going to stop immediately and send them to the hospital. Now let's talk about some of the other kind of blocks that we can have. Here you can see a bundle branch block, and what we have here is some sort of impairment or blockage farther down the line. So it's somewhere within the Hirsch-Purkinje system. You can have here, so we've got normal conduction through the SA node and the AV node, and then farther on down is where we see the block, and it can be in either the right or the left. Here you can see that the blockage is on the right hand side and the left is working normally, or we can see the opposite where we can see a blockage on the left hand side, and so the right is able to depolarize normally. Now let's talk about some of the other cardiac abnormalities that we may see on EKGs. The big one here that we'll see and we'll talk about, and there's a variety of them, but I wanted just to kind of talk about basic things here. Let's talk about ischemia and infarction. And these show up on EKGs a little bit differently. With ischemia and infarction, we see movement of the ST segment. Remember that the ST segment is that baseline, that brief period of time where the EKG kind of resets back to baseline before we have that deep or that repolarization of the ventricles. And so we can identify that whenever we see changes or movement of that ST segment up or down, and it's got to be usually larger than a millimeter or so. The T wave, once again, should always kind of mirror the direction of the QRS complex. So if the QRS complex is up, the T wave should be up. Here we can see ischemia and infarction, once again, some of the changes that we can see. We can see ST changes, we can see depression. Here you can see depression in the upper right-hand side. Depression of the ST segment is very suggestive of ischemia. So the heart is being starved of oxygen, and it's being overworked more than it can, tolerate. And so if we were to reestablish, positive flow between supply and demand, then we would most likely see that ST depression kind of return back to baseline. Now we can also see movement of the ST segment upwards, elevation of the QRS or the ST segment, and that's more suggestive of infarction. So down below you can see we have the evolution of an acute MI. So we have an infarction. You can see the ST segment in A is normal, and then all of a sudden in B now we see elevation of the ST segment, and then in C now it's really elevated. And not only that, but then in D, as that infarction becomes older, then we're going to see generation or establishment of not only ST elevation, but also the Q wave, which is very prominent. That's the first downtick in the QRS complex. And then over time, that T wave is going to become inverted. Now, T wave inversion, very similar to ST depression or elevation, it's suggestive of either ischemia or infarction. So those are some signs and symptoms that let you know, hey, we've got some changes going on and they're not good changes. Now, as I mentioned before, Q waves, prominent Q waves can be an indication of necrosis. In order for them to be significant, though, they need to be either wider than 1 millimeter in width or greater in amplitude, greater than 1/3 of the total QRS complex. Now, you may see Q waves, on a lot of different EKG tracings, but the vast majority of them there are insignificant because they don't meet these two parameters. So a Q wave, if it's significant, it is indicative of or suggestive of an old myocardial infarction. And so that may warrant further investigation from the cardiologist. All right, thank you for listening. If there's any questions, please contact me via email.